Recently, the Society for Vascular Surgery has decided to sponsor an audiovisual archive to feature the outstanding leaders and contributors in vascular surgery. A committee composed of Jimmy Yao, Norm Rich, Cal Ernst, and me was formed to undertake interviews of our most famous and distinguished colleagues. My name is Roger Gregory, and today I will be conducting an interview with the legendary surgeon, Dr. Anthony Imparto. Dr. Imparto, thank you for agreeing to this interview.
Happy to do it. Thank you for inviting me.
You were born in New York, but you've always been in New York. Is that right?
Most of my life, but not entirely. Born in Brooklyn. At the age of 8, I was shipped off to one of the Pontine Islands, which is the ancestral home of my father. It's an island that had been colonized by the Romans.
Well,
Why?
Why did this happen?
Well, I was a skinny kid. And you know, amongst Italian families, skinny kids aren't permitted. So they decided to send me back to my father's ancestral island so I could learn how to eat.
Did you learn Italian too?
Oh, yes. Yeah. Oh, I indeed. I not only went to the public school, but then had a schoolmaster after school. And I went afternoon for private lessons. So in 2 years, I knew the dialect, but in 2 years I learned, formal Italian, and I've retained that pretty much. And I can fool most Italians into thinking that I'm an Italian.
So you returned at age 10 to needing to relearn English and went to high school then in the United States.
Yes, I did.
In New York.
Yes, yeah.
At Utrecht?
New Utrecht.
New Utrecht.
New Utrecht.
New Utrecht.
Yeah.
Now, tell me about college.
Went to Columbia. It was interesting because 5 of us from that little-known high school in Brooklyn were accepted to Columbia the same year. And it was an eye-opening experience because it seemed to me that the faculty was made up of skeptics and nothing else. But it was a great educational experience. It was the main thrust of the school was a 2-year program which was called the Humanities and Contemporary Civilization, which is a broad survey course.
Now, what did you major in?
I was a pre-medical student, and we had no majors in those days. We simply satisfied the requirements of the college for the mandatory courses, and then the requirements imposed on us by the medical schools.
What got you interested in medical school?
I've thought about that. I'm not quite sure. No one ever pressured me. The only physicians I knew in growing up were the family physicians who usually had, in the residential neighborhoods of Brooklyn, they usually had their offices on one of the major corners in the neighborhood, and they were available to come to see you at home, or you went to see them. And maybe that's what inspired me. I don't know.
But you went to New York Medical School.
No, New York University Medical School.
New York University Medical School. And graduated in 1946.
Correct.
AOA.
Yes.
So you did well with it.
Apparently that's considered, but they give you a little gold thing that you put on your lapel or on your necktie.
In 1943, you got married.
Yes, after the first year of medical school.
To Agatha
Petriccioni.
Petriccioni.
Petriccioni, yeah.
Right. Who I've heard is a very beautiful woman.
Yes. Yes, a beautiful woman.
How did this happen to you?
I don't know. But actually, there's a very interesting story about that. I learned only a long time afterwards. I was acting on the stage in a high school program.
Really?
Yeah, and Agatha and a young woman with whom she'd grown up since the age of 3, they came to see the play, and she was smitten. Now, she never admitted that for many, many years, but one day she whispered it into my ear. And of course, I had to believe her, because you never disbelieve your wife.
Of course. Now, when you decided to do a residency, you were first interested in internal medicine.
Yes, oh yeah.
Why did you change to surgery?
This was under the influence of one of the NYU professors, surgeons, Dr. Sam Standard, who was, in his spare time, was a Talmudic scholar. And he was a basketball aficionado. And we had gotten to know each other, during rounds and things of that sort. And when it was time to leave the medical school and go into the Navy, he suggested that I come to see him before making a final career decision, because he thought maybe I should consider surgery. I tried to find out why. And the explanation he gave was hard to believe, but he said, I can watch a basketball player shoot baskets 3 or 4 times, and I can tell you whether he's going to be a good basketball player or not. And believe it or not, that's the basis for, well, there's more than that. Finally, after my duty in the Navy, I then got to see firsthand what the surgical discipline was like. But it was Sam Standard then who really, and he then helped, plan the applications to surgical residency programs after my Navy experience.
Now, first you did a year of anatomy at NYU.
Teaching anatomy.
Who was Homer Smith, and what influence did he have on you?
Homer Smith was one of the original renal physiologists. He, for instance, had been in Egypt and had dug up the lungfish and found out that the lungfish could live in the mud and its kidneys would function, and worked out the anatomy of that, wrote a textbook. So he was a pretty good physiologist. As a matter of fact, he was world-renowned in the field. And when it came time to go to apply for surgical residencies, there were so many people coming out of the service that they had filled up the jobs. I got out in May, and it was too late. So I went to see him, and I told him that I thought, as an aspiring surgeon, I should spend a year in physiology while I was waiting. And he gave me a little lecture. He said that if I were going to become a surgeon, it would be more advantageous to me if I learned some anatomy, because he didn't know any surgeons who knew any anatomy. Those were his direct words.
Well,
so he sent me over to see Dr. Donald Sheehan, who is the professor of anatomy, and he gave me a fellowship, a teaching fellowship, and it was a wonderful experience because I spent the whole year, first in preparation, I spent the whole summer dissecting my own specimens, and then when the undergraduate students and the postgraduate students who were coming out of the service came for their anatomy instruction, I had contact with not only the undergraduate students, but the postgraduate students in every field that you can think of. There were obstetricians and gynecologists who had spent several years in the service, hadn't seen, and it's the same thing with all of them, thoracic surgeons, whatnot. So that year was very valuable as a starter. The next lucky thing that happened was that the professor of the 3rd Division at Bellevue Hospital turned me down for a job. But J. William Hinton of the postgraduate division snapped me up, and I started again as a surgical intern.
at that time you did some work on gastric vagal effect.
Yeah, I did. That was in the days when vagotomy was in its heyday. And Dr. Hinton had realized that this was an operation. He did a number of them. This was an operation that did not have lasting effects and sometimes had no effect. And so he and one of the anatomists, an Austrian by the name of Joseph Pick, who was interested in the embryology of the autonomic nervous system, felt that it would be feasible to surgically perform an experiment that would indicate whether there were pathways, whether there were autonomic pathways that were producing acetylcholine going directly to the stomach after the vagi had been cut. And so what we devised was cross-nerve anastomoses. So we did the vagus, proximal vagus, to the distal sympathetic splanchnic in the chest, did the sympathetic splanchnic to the distal vagus, and actually used Koch's postulates to determine whether whatever the result might be was valid or not. We tested the animals, did our resections, did our nerve anastomoses, indicated all along the line when function was present, when it disappeared, when it returned by physiologic stimulation, insulin, Hollander test. But when that was completed, so that there was no question that this was a valid response, we used prolonged electrical stimulation proximal to the anastomoses. And we stimulated a most difficult test to complete. That is, one had to deplete the pepsinogen granules in the stomach. And by the time that happened, there was no question but that there had to be pathways. When that was done, and we had demonstrated both physiologic return and this anatomical thing, we then resected the anastomoses and repeated the whole business and showed that now function, what had been returned, disappeared again when the anastomoses were out. And that basically satisfies Koch's postulates for determining the etiology of an infectious process.
So here you were working on gastric and GI areas, but you were also impressed with Jerry Lloyd.
Yes.
And vascular surgery.
That's right.
Tell us about Jerry Lloyd.
Jerry Lloyd had been working up at Columbia and had devised a technique for anastomosing in doing portocable shunts, portosystemic shunts, a technique of anastomosis which was a non-suture technique. And he was recruited by Dr. Hinton, who had married his sister, Jerry's sister, by the way, had recruited Jerry to come down to NYU, the postgraduate division, to set up a vascular program. And the vascular program in those days was closed hearts. 1952, the first endarterectomy of ephemeral was done at Bellevue. Dr. Lord and Peter Stone did them. I was a junior resident at that time. Then when it became apparent that I was going to be a chief resident of we usually had about 8 residents who completed, 8 full residents. One of those was slated to be the chief resident and he, in his year before he became chief resident, had additional training in vascular and cardiac surgery. And the way that was done is if Jerry Lord had a case to do in postgraduate hospital, which was a cardiac case, I would be shipped off to the system. And so it was with aneurysms. We were wrapping thoracic aneurysms. The plastic prosthesis had just come out of Columbia. That was in Voorhees. He and I were contemporaries, as a matter of fact. He presented his work on on the plastic prosthesis Vignon on the same program, the same day. They used to have all the residents present their experimental work on the same day that I presented my work on gastric physiology.
Now, in your post-residency training, where did you go for that?
I trained all there, all at NYU.
But you were interrupted by some military service in 1946. But you still stayed in Brooklyn.
The family lived in Brooklyn, yeah, and I traveled beyond that. But I went into the service in 46, was there until 49, and then in the middle of the internship in 50-51, because I was in the organized Naval Reserve, I was reactivated for the Korean conflict. That only lasted for 8 months, and then they let me out because of my previous service. So then I went back to NYU and resumed my surgical internship.
Let's get back to your personal life for a moment. When exactly did you get married during this time of your training?
At 1943, which was upon completion of the first year of medical school. They posted a no exam list. So Agatha and I convinced our parents, mine and hers, that it was time for us to get married, in spite of the fact, we had $50 a month. But that's when we got married.
Tell me about sports that you were involved in. You played football in high school.
Did not play on, my father would not let me play, not touch tackle, would not let me play on the varsity teams, yeah. He thought it was too dangerous, but I could pass and kick. I had the talent to drop kick, not the place kick, but the drop kick, and I could pass. Well, in Brooklyn it was measured in sewers. I could pass about 1.5 sewers. But he said, no, you're too dangerous for you, don't do it.
And fishing became a big hobby for you, including going to Iceland to fish.
Well, I started fishing with my father when I was a little kid. He was an avid fisherman. He came from an island, and so it started there.
You also were involved in, you mentioned you were involved in acting and some music and art.
Yeah.
Growing up.
Yeah. I did some acting and did a little bit in college as well. And I'm doing some now, by the way. Somebody volunteered me.
Now, to move to your practice, where and when, I'm a little confused by all these twists and turns, GI and pediatric surgery, and finally vascular surgery. So what attracted you to focus on vascular surgery?
Went to California after the completion of my surgical residency. The reason was the Professor Hinton had a plan for setting up a multidisciplinary surgical group in the university so that the faculty members could earn their own living. He believed in the independence of thought and that one way to do it is not be dependent upon somebody else for your income. And that was planned, and he invited me to join the group before I finished. And as it was getting underway, 2 of the senior members had terrible personality conflicts, and the whole thing fell apart. So I guess in a moment of pique, I said, well, let's see what's going on in the rest of the world. So we finally found a place in California with a group, Northern California, Santa Rosa, and worked there for 2 years. And I did everything that I had done in residency. I did chest, and I did abdomen, and I did pediatric surgery and things of that sort. And what intrigued me most at the time, about that time that Rob Pickering and wrote about their operation on the carotid. Eastcott, yeah, Eastcott, Pickering, and Rob. They wrote about it. But when I decided that the non-academic environment was something that I missed, in spite of the fact that I was operating like, doing lots of surgery, we decided to come back to the university. And when I came back, I was so intrigued by some of the newborn infant surgical procedures I did. As a matter of fact, there's a paper on there on the subject, the tube duodenostomy, that when the professor asked me what I wanted to do, I said, well, I'd like to do pediatric surgery. And he said, fine. There was another man who was doing it. He said, good, go work with Jerry Lord in the heart program, heart vascular program. So I went and joined the heart and vascular program. Shortly afterwards, the heart-lung machine came along. So we did some of that. Jerry then was not spending very much time at Bellevue for vascular cases. And when I came back and realized that residents were doing amputations but very little else in terms of vascular disease, we decided to get them interested in more extensive procedures. And that sort of, fell into it in a sense.
Yeah. Talk for a moment about the atherosclerotic plaque. What made you think that branch points and plaque hemorrhage were such important factors?
The idea about the localization of the atherosclerotic lesions, of course, had been described a long time ago. But this man, Meyer Texan, who worked in the medical examiner's office, was impressed with the same fact. He consulted a hydraulic engineer at Columbia, and the hydraulic engineer and he got together and decided that the plaques were occurring at a place where one could describe the flow as reproducing the Bernoulli phenomenon, high flow, low lateral pressure. And this was diminished lateral pressure. And Jerry Lord decided, with the Texans' encouragement and Hinton's encouragement, that perhaps we could reproduce experimentally the configurations in the arterial system that were related to atherosclerosis. So the first one we did was simply to take a vascular graft, a vein, and transect a native artery and put in a graft that resulted in a big curvature. Lo and behold, the proliferative lesions that occurred at where they were supposed to, at the sites of curvature.
Talk about hemorrhage.
That came on inspection of the carotid plaques. That came later. But with the experience in the laboratory, we then reproduced all the other configurations, narrowing, things of that sort. But with the experience in the laboratory, it then became apparent that during the joint study, when we would get together every 3 months and discuss what we had been seeing in the operating room, it turned out that no two people were describing the same type of plaque. At that time, the aspirin study had come along, and the neurologists were talking about the fact that all of this is explained by platelets. And I joined the study and blackmailed them so that they would give me what's called a Coreco camera. This is a huge camera that permits you to take magnified photographs. And so upon opening the carotid bifurcation, we would take photographs, hoping to be able to see platelet aggregates. We never found, well, we found them, but they weren't a counting phenomenon. But this permitted us to photograph a large number of plaques. And it was at that point we realized that this was a complex process. It wasn't simply the insedation of fat into the arterial wall, because there were all sorts of things. The final convincing operation to me was in a patient who's relatively young, he must have been in his middle 40s or something, who was having repeated transient ischemic attacks. And when we opened his carotid, what we found was there was a veil over a clot, which was under the veil, was in the wall of the vessel. And we have pictures of that. And then it became apparent that some of these things that were being called thrombus were not thrombus. They were actually intramural hemorrhages. And of course, once we knew that, you see, we could examine these things in the operating room and photograph them without disrupting them.
In 1962, you actually started a vascular fellowship, much earlier than has been previously reported. This was suggested by Dr. Roy Claus. Talk about that for a moment.
Serendipity.
How did this happen?
Greek general was carted off to Houston, either saw a Debakir or Cooley, who did some procedure on him. I think it was an aneurysm. And he was accompanied by this young, well-trained Greek general surgeon, George Sanoudas. And when he was discharged from Houston and was flying back to Greece, they got an hour or 2 hours out of Houston. They were close to New York. The general developed a spiking fever. And so he was so sick that he had to land. Now, George Sanoudas had been a friend of Roy Claus's. And George Sanoudas told Roy Claus that he was interested in getting training in vascular surgery. Was there some way to do it? And Roy called me because we were very active in doing vascular cases. Tony, why don't you take this fellow on as a fellow? Okay, we'll take him on as a fellow. It sounds like a good idea. You know, we'll spread the gospel, as it were. And that started the fellowship. So then we continued each year, took on a vascular fellow.
What happened to the patient with the spiking fever? Did he?
Oh, he was treated. He got well, went home. Went home with George, and George came back. And after he finished with me, he then went on and worked in Frank Spencer's heart program. So he had his cardiac training as well as his vascular training, and then went back to Greece.
I want to mention your career highlights for a moment. You were able to unite SVS and AAVS, I think in 2003. This was clearly a giant undertaking and a giant success. You were SVS president in 1985 and received the Distinguished Service Award from SVS in 2003. Some of the other things that I thought were somewhat amazing, the fact that you recognize the significance of claudication as far as the fact that a superficial femoral artery occlusion was not an indication for immediate surgery. Often these patients improved with time and exercise.
That's right.
Contrary to what was being taught. You were the first to recognize failure of the Dacron graft after aneurysm surgery, which really led to graft redesign, which was a giant success. And as we've already mentioned, the first to really notice the significance of hemorrhage in the carotid plaque. All these were giant observations.
We made another observation.
On the failure of arterial reconstruction and the importance of better technique, which all of your fellows and residents have benefited from. What was the other observation?
Intimal hyperplasia as the basis for the failure of many bypass procedures, basically. And that was based upon something that had been described a long time before, that is, when blood clots in a flowing stream, it clots because platelets deposit somewhere on the arterial wall, and you get a little bit of, you get fibrin, and you get a few blood cells, and you get the salmon clot. And it's only after that salmon clot forms and slows the blood flow that you get the stasis clot. And so it was possible to show, the way prostheses were being studied in those days, we had a vascular registry. Surgeon would explore a patient who had a late failed prosthesis, chop a piece of prosthesis in the middle and send it to the pathologist. And what was in those prostheses at that segment was red clot, was stasis clot. And the thing that I postulated was there must be a place where the flow of blood was interrupted or slowed down that started the whole process. And so when I explored any failed arterial reconstruction, I not only inspected the whole prosthesis, but also went to look for the salmon clot, the flow clot, flow thrombus. And it was possible to find that the flow thrombus was found at the site where the intimal hyperplasia occurred.
With this long list of dramatic successes, I think it's fair to say that it's very easy to accept success, but it might be difficult to accept failure. Yet as a human being, we all have disappointments and failures. Did you have failures in your career?
Oh, yeah.
How did this affect you?
Well, we try to put it to good use. You know, we had arterial reconstructions that failed. For instance, carotids. We had some carotid procedures failed. And so we devised a method for investigating the whole process, including tissues. And it was upon that we discovered, to our satisfaction, that in spite of the fact that the residents who would come for interviews for their vascular traineeships, I had a standard question. Suppose your professor operates on a carotid artery one day, and that evening the patient's reconstruction fails, or the patient has a stroke. What does your professor say happened? Well, there was usually a stock answer, you know, embolization or something of that sort. So at that point, we decided that we had to do a more definitive evaluation. Upon that, we found, again to our satisfaction, that most of the failures were due to some type of technical
Misadventure.
misadventure, yeah. That a few of them were beyond our control as far as we knew. The intracranial hemorrhage, things of that sort, were never really fully explained. But we could find, again, that surgical misadventures were the major cause of failure of carotid endarterectomy.
Hundreds of general surgeons were coming out about your time that had an interest in cardiac and vascular. What made you so different?
My mother and father. This is why I mentioned the curriculum at Columbia. And when I came to NYU, I found the same attitude, that people were, for instance, the hypertension group. About the time that the people down south were advocating rice as a cure for hypertension,
At Duke.
these guys said, well, now let's see, how well did they control their experiment? So what they did is they admitted the patients to the hospital, fed some of them rice, fed others a general diet, and found out that both groups had equal response in their hypertension, that it was the bed rest that was probably doing it. But there were a number of instances in which that kind of, a man by the name of Goldring, who was an excellent clinician, who would make astute observations on individual patients that were completely contrary to what had seemed obvious. I think, it's sort of an accumulation of experiences of that sort, perhaps. Maybe my father did too, He had a very elementary education on his island, but as I was growing up, he was drawing plans for desalination of ocean water for his little island. The Romans had set up an aqueduct system, but he had a plan, would draw plans for how to raise ocean water to the top of a cliff using wind power. It's a windy island, then having it evaporate, having the water evaporate and leaving the salt behind, and then running that condensed water down the hill to his little village down there. Is that where it came from? I don't know. Possibly.
Who were your mentor? Who do you consider your mentors? Who influenced you and why? What were their qualities?
There's a man in grade school by the name of Gannard. He was, he was the epitome of rectitude, both personally and for a seventh grader academically as well. In my latter years, I think one of the greatest was Hinton, J. William Hinton. He was a most remarkable person. Jerry was a good influence because he helped us to, not only with the clinical work, but the attitude towards experimental work in vascular problems. I'd have to think of a lot of people, but those are the ones that come to mind right now, most directly with vascular surgery.
Our committee has come up with several specific questions that they would like your opinion on. The first is, what is your opinion of endovascular surgery, particularly in the carotid position?
I was on a panel with, what's his name out in Arizona?
Dietrich?
Yeah, Dietrich. In the very early days when and I asked him a question to show you how early, because I knew what the carotids were like inside, and he obviously didn't. I asked him if he's doing any studies of the brain following his putting catheters in there. He said, "Oh, we're not doing it now. We're going to do it. Soon we're going to do it. Going to do it." Of course, I never saw it done. Maybe he did, but I never saw it published. So that's been my basic attitude, that this is an approach which is not as controllable as the open procedure is. I don't think that taking a series of endovascular procedures as they are now done and comparing them to the durability of an open procedure well done, I don't think there's ever going to be a comparability. I don't think the endovascular, on the basis of the anatomy and the physiology and the pathology that's involved, that it can ever match the precision of the open procedure. So I think there may be a place for endovascular procedures, but I'm not convinced that I know what that place is.
Let me ask you for an opinion on the Independent Board of Vascular Surgery. As you know, this was advocated by Frank Veith and Jim Stanley and many others, including myself. Why did this fail?
Turf. I think it's turf. Yeah. Unfortunately, yeah.
Now, do you think if we had had someone as diplomatic as Tony Imparto, would we have done better?
I remember in the early days I asked Jack Wiley why we weren't taking a firmer stand in opposing whoever didn't want us to have a vascular board. And basically the thing he said was, like Teddy Roosevelt, speak softly and carry a big stick. If we go at it slowly and diplomatically, I think in retrospect, that was not the right. I think if a firmer stand had been taken earlier, it perhaps the general development of the field might have been different. Now, whether it been any better or not, I don't know. I have a firm feeling that there would be better control. I think perhaps the tremendous thrust for endovascular surgery, which has had, to me, a very troublesome course, could have been avoided. We put a lot of patients through terrible, terrible trials trying to work out the whole business of endovascular surgery when we had a perfectly good operation.
I think we can all agree that American medical care has become a political football. Is American medicine losing its way?
Well, my prejudice is yes, but right now I'd have to leave it as a prejudice, yeah, because I think there are so many well-intentioned and brilliant people in the field that maybe there are enough around to keep it on some kind of an even keel. But we hope. The politics and the economics are overwhelming, overwhelming.
Now, this will seem like an unusual question, but we must have an answer. Norman Rich asked you to make a house call one Sunday at the Waldorf Towers.
Marlene Dietrich.
Yes. What was that all about?
Well, it was a Sunday afternoon, and there I was. I know Agatha and I were talking about either going to dinner or going to the movies or something, and I got a call and said, Marlene Dietrich is up in that hotel, and would you go to see her? Okay, fine. So I went up to see her, and she had what she had actually was a Lariche. She had a thrombosed aorta, she'd bumped her stage or something of that sort. And I spent time after examining her trying to convince her that she needed some real help and wouldn't she like to go into the hospital, and she absolutely refused. So, but, if somebody needed help. I'd practiced 2 years in California where I drove miles and miles to see patients who couldn't be treated any other way.
I think I know the answer to this, but I have to ask. In retrospect, what was your favorite operation?
I think it was carotid because of the end organ involved, the brain. That's the prime organ in the body. It's the one that can't take any insult at all, and so requires a lot to protect it. And I think both the challenge and maintaining the integrity of this great organ is what made the operation particularly challenging to me and my favorite.
What advice do you have for young surgeons now?
Learn how to operate. Learn how to operate.
Dr. Imparto, thank you for allowing us to spend time with you today.
Thank you very much. It's my privilege, I assure you.